Hi, everybody. Oh, we've got lots and lots of folks.
We do. We're so excited that everyone's here. Lisa, can you acknowledge that you can at least hear us or All right, I'm going to start sharing my screen and hopefully Lisa can join us and start. Let's go ahead. All right, Kim, can you see my screen?
I can. I can.
All right. So we welcome all of you. Um, this is a project that we have been working on for a while now, but we were grateful in collaborating as a part of the Erase MMR project, which is a CDC grant that we've received from the CDC, and also working with the Perinatal Quality Collaborative and some of our partners at the DHMIC. We have started to work. On this project, and we are very excited to show it to you today. And the good thing about it is that you're going to be able to really comment and give your opinion. We want to hear from you. As we just learned in the last panel, we want to hear people's voices. We want to hear people's stories. So if you have any comments, we want to take them into heart. So Kim Petrella is with us, and also Lisa Klein, but I think she's struggling to get on here. We haven't heard from her yet. So I will go to the next slide. So our objective is to describe the status of the MMR in Delaware, that is maternal morbidity and mortality, the Child Death Review Commission, which Representative Minor Brown mentioned. We oversee the MMRC, which is the Maternal Mortality Review Committee. We're going to look at some of the national programs we looked at to plan this, our key goals for Delaware, and we're going to show you multiple formats of how the maternal warning signs are going to come out, and then also some thoughts from our stakeholders. We're going to ask you for that at the time. All right. So, Lisa, can you hear us? Are you ready to go?
I can you hear me? More importantly,
Yes, we can hear you, and the slides are
yay!
showing. Yay. Welcome.
It has. I've been struggling with getting it to open. It just didn't want to seem to open. I've been watching a little circle go round and round. So, well, first, I'd like to really appreciate Dr. Marshala Lee talking about urgent maternal warning signs, which is something that is really important for us to be able to talk about and for us to be able to make sure that women understand when there's a problem and what they need to do. I'm the coordinator for maternal mortality review. I don't want to see the women. I don't want them getting as far as me. And I know when Kim talks about the morbidity, we don't want them to get that far either. So that's why we want to try to educate. But it's important when we educate, it's important that you know where we're coming from and why we need to be doing this. So I want to tell you a little bit about maternal mortality in Delaware between 2017 and 2021. During that time, we reviewed 35 deaths of birthing persons. And it's important to understand, gratefully, Delaware only has about maybe 8 to 12 maternal deaths a year. However, because the numbers are so small and we want to protect the identities of people, we aggregate or we group together the deaths. And so we report out our data based on a group of years as opposed to each year. It's not that we're trying to prevent any information from getting out there. It's really that we're trying to protect the identities of the women because there are so few of them. So we had 35 deaths between 2017 and 2021. 1 in 4 cases, just over 25%, were likely to be pregnancy related, meaning that the woman's death was linked directly to her being pregnant. If she had not been pregnant, something about the pregnancy, whether it was a clinical issue or whether it was a social issue or whether it was a substance use mental health issue, for some reason, the pregnancy was related to why this woman died. 74% of the cases we identified as being associated with pregnancy, but not related directly to the pregnancy, or we were not able to really say whether or not the pregnancy influenced the death of the woman. We continue to see significant racial disparities in both the number of deaths of Black birthing persons and the pregnancy relation by race. And an overwhelming number of these deaths, our Maternal Mortality Review Committee in Delaware determined that the deaths were preventable, meaning that actions might have been taken before the death or during the final incident that may have prevented the outcome of death. Next slide, please. So this slide might be a little confusing, but the first thing to know is that in the top box, we're talking about how many live births we had in Delaware, and we're using 2019. We just selected a particular year. In 2019, 28% of the births in Delaware were to African-American Black women. We had about 50% of the births to white women, and then Hispanic women and other races made up the rest of them. But when you look at the maternal mortality cases that we reviewed, in the pregnancy-related deaths, 78% of those pregnancy-related deaths were to African-American women. And 38% of the deaths that we could not determine or were found to be not pregnancy-related were also to African-American women. If you look at the population of Delaware, 31% of the women are African-American. So this really points out the disparity that we continue to have, similar to the rest of the country, in the deaths of African-American women versus white women in related in pregnancy and pregnancy-associated and pregnancy-related deaths. Next slide, please. So when are women dying in Delaware? Well, what we're finding is that about 22 to 23% of women die when they're pregnant. And 22% of the pregnant deaths, of the deaths of pregnant persons, were pregnancy related, and 23% were not pregnancy related. So you say, how on earth could the death of a pregnant woman not be pregnancy related? She might have died in a car accident. She may have had an overdose that was not related to the pregnancy. Those are some of the reasons why you can have a death during pregnancy, but it's not related to the pregnancy. And then 44% of our pregnancy-related deaths are in the first 6 weeks after delivery. 12% of those are determined the unrelated or unable to determine. And then 33% of the pregnancy-related deaths are 6 weeks to a full year after the delivery. 65% of those are not identified as pregnancy-related or were unable to determine. Next slide, please. This slide to me is so important because the deaths of women in Delaware from substance use disorder and mental health disorders is a growing issue. Almost half of the cases that we reviewed between 2017 and 2021 had both substance use disorder and mental health disorders identified as contributing factors to the death. We only had one death where there was just a mental health disorder that we did not identify any substance use disorder. But substance use disorder is a tremendous issue in the state and something that we need to figure out how to get a handle on. Next slide, please. So I also mentioned that we talked about that deaths being preventable. What are things that could be done? And this is one of the focuses of the Maternal Mortality Review Committee. When we do a review of a death, we're trying to identify why this woman died and what could have been done to prevent the death. We're not assigning blame. We're not a quality review committee. We're not looking at providers or hospitals and saying somebody did something wrong. We're trying to look at system issues. What are system issues that we might be able to have some control over that might be able to prevent these birthing persons from dying? And again, 89% of pregnancy-related deaths we thought were preventable, and 81% of pregnancy-associated, not related, or unable to determine deaths were determined to be preventable. Next slide, please. And here I'm going to turn over to my colleague, Kim.
How are you? First of all, let's see. So we were looking at maternal mortality in Delaware. Some of the things that we can do is to actually look at FEMUR data, which is the Fetal Infant Mortality Review data. And those are pregnancy complications that have been contributed to fetal deaths and neonatal deaths, especially from preterm deliveries. So of those FEMUR deaths, we had 6 that had severe maternal morbidity, which means that the person was sick enough that they ended up getting a transfusion of at least 2 units of packed RBCs or red blood cells. They could have gone into the ICU, things like that. So of those cases, 5 of them had underlying anemia, and not just the OB hemorrhage. The maternal interviews, which Lisa does, suggest that there was a lack of knowledge of those pregnancy complications, meaning that maybe pregnant women didn't know that they had anemia, or maybe they didn't know that they should be taking extra iron or something like that, or other types of complications that they just were completely unaware of. They also had the inability to communicate the urgency of an issue to their providers. And that's when all of a sudden the lights and the bells went off in all of our heads. And they reported feeling dismissiveness on part of providers and or staff. And at this time, I'd like to acknowledge April Lyons Allen, all. She contributed to this a huge amount. So I'm sorry, April, you know me. When I get tongue-tied, sometimes I say all kinds of crazy stuff. So next
huge
slide,
shout out.
All righty. Next slide, please, Anne.
Sure.
Okay, so what we did, we decided that, it was time. It was time to be able to find something that we could give to women to empower them, something that they could look at on their refrigerator, look at in their wallet, something like that, that would say, this is a warning sign that you need to either call 911 or you need to, get to the emergency room, calling your physician or something like that. So we needed to distinguish between when to call the provider and when to call 911. And that also includes support people that are living at home that may not have known. We wanted to make sure that those colors that we used on this graphic promoted a sense of urgency. So we wanted to make sure that we had the McDonald's colors, the red that means 911, emergency, huge, the yellow that meant, whoa, this is a warning sign that requires some type of action that we need to be, taken care of. And we wanted to focus on all of pregnancy, not just postpartum. Some of the, you'll see in a minute, some of the other sources that we looked at just constantly would say postpartum warning signs. We wanted something that was in the entire pregnancy. And mental health issues are also addressed. And we wanted to make sure that we had things that we could use for patients to be able to kind of reach out for. And the other problem was that the papers that were available had a very high reading level. They were using a lot of medical jargon. And in emergency, you just saw I couldn't even say April's name. So I mean, you just get tongue-tied sometimes. And, if it's an emergency, you certainly do have a difficulty expressing what you're trying to say to a 911 operator. So what we did is we looked at these different things. We looked at the figures of different races. We looked at different pictographs. We wanted to make sure that, again, that they would be able to tell somebody what to do. So let's see what happened. Next slide, please. All right, so this was A1, and again, it's called post-birth warning signs, and we really wanted to make something that was the entire pregnancy. So you can see here that, yes, they did have 2 of the, or 3 of the little things that we were really trying. They had the call 911 issues, and they had the call the healthcare provider, but sometimes in an emergency, it's difficult to sit there and read through something like this and be able to make a determination of what you're supposed to do. So next slide, please. And this is something that came out from AIM. A lot of you who may work in hospitals might be familiar with AIM. That's the Alliance for the Innovation of Maternal Health. Hence, we call it AIM because that's such a huge mouthful. And they did have a lot of pictures, which we really liked. We liked the fact that there were pictures. We liked the fact that they were of different races. We liked the fact that even if you were not a native English speaker or whatever language that this was in, you could at least tell by the pictures that something was amiss. But the problem, again, with this is that it didn't distinguish between the call 911, and believe me, being a 911 operator, getting a phone call that someone's having vaginal bleeding or fluid leaking after your pregnancy is not what they want to hear. Next slide, please. So our key goals, again, were literacy, making sure that, we had pictures that demonstrated the issues. We wanted to make sure that it was a low enough reading level that it could be handled in an emergency. We wanted it to be easily translated into other languages, and we wanted it to be able to be used. I mean, sometimes there might be mom and just her 8-year-old there, and the 8-year-old might not be able to read the big words, but could tell because of a picture and a next to an ambulance that that's a big problem. And we also wanted to give a little bit of a script, something that kind of helped the patients kind of figure out what to say to indicate that urgency and the seriousness. And next slide, please. So we also wanted to make sure that when we use the interpreters, that we could validate with our providers and our support staff that the messages also resonated with non-English proficient persons. I mean, there's nothing worse than having an emergency and not being able to say what you need because you don't know how to speak the language. So we wanted to make sure, again, with our stakeholders, that we had something that was visibly attractive, something that said what we needed it to say, something that validated what we've heard, what we've had patients ask us for, and something that was very empowering to patients, in the hope that if they seek help earlier, that, again, as Lisa had said, some of those situations that ended up resulting in a death were preventable if something would have been done sooner than that last situation. So if we could jump in before this situation became completely life-threatening to the point of where we couldn't do anything about it, then we've accomplished our goal. So next slide, please. So what we did is we chit-chatted with AIM. We had many, many talks with them. AIM, we just talked about a second ago, and also ACOG. And we asked them for their use of their pictures, and we asked them for the use of some of their translations. We also decided that, it's not a one-stop shop. We needed other things in our toolkit. And April was very instrumental in that. And so we talked about having a wall poster, a wallet card, things like that. And we wanted to go after multiple ways to be able to get to the patients, going to the OB offices, putting things in triage, in the emergency rooms, having doulas, community health workers, home visitors, and even in WIC offices. And, hey, I'm fine with having them in 7-Elevens too. We just need to put them where the people are so that they can be picked up. They can be, it's only as good as when it's available when you need it. So it really needs to be in the right hands. So please go to the next slide. Thank you. So we had 2 surveys that we've created, and we've put these in SurveyMonkey, one of which is for a provider who may be working with patients, and I want you to look at it from that lens. And then we also have a survey in SurveyMonkey, and we're going to be asking you to participate in those for us today, not while we're in the session, but sometime within the next couple days. But also looking at it through a community lens. What would you think about this as a patient? If you were, at home by yourself and you experienced one of these urgent maternal warning signs, would you feel, oh my gosh, well, it's here in print, so I better do something about it before it ends up leading to something else? So far, we've had 20 professionals and 6 consumers, but we want to continue. So this is the final product. This is what we've done. And this, believe me, when I say final product, it's probably version 214, because we really wanted to make sure that we had everything in it that we have been talking about throughout this presentation. We wanted to make sure that people understand that this is not just some pretty thing to put on, an exam room wall or something. This was actually something we needed people to read and to understand, to ask questions about while they're in front of their OB or at their practice or something. So we do have the picture. Call 911 if the following things happens to you. And here it is again. But it also, we talk about these things so that, even if you can't read, even if a 5-year-old is looking at this paper, hopefully that will, at least help be able to communicate to whomever that person is talking to that this is a true life-threatening emergency, and I am not calling an ambulance for a ride to the hospital. This is it. This is the time we need to intervene. We also decided to add that script, as we said. So what do you say? You get to the emergency room. Sometimes if you've already delivered, you might not look pregnant. So you may need to tell them that, I've been pregnant. I had a C-section. I had a delivery here or there. So-and-so is my doctor. I delivered at so-and-so hospital. And I'm experiencing an urgent maternal warning sign. I am having trouble breathing. I am having a headache. I've done everything I can think of. Nothing's making it go away. I have a change in vision. all of that. We want to keep cases out of Lisa's hands, off of her desk. That's the goal. So next slide, please. Okay, the next one is those call the doctor today kind of things. And, be a little bit persistent, because sometimes, you get a million phone calls, and whatever line of business you're in, if you get the same phone call all day long, they all tend to blend into one another. How does that patient actually say to this provider, I know you've gotten 14 people that have called today with fever, but mine is something that I really need to be, to have discussed today. I need to tell somebody. I need to tell somebody that I have been throwing up. This is not morning sickness. This is something that I am really sick. I cannot get out of my chair. I'm so tired. My baby has not moved at all in the last 2 hours. These are the types of things that need to be addressed the day that they are getting to the point where they're getting this severe, so that we can intersect before we have problems. So that is the main goal, empowering people who are having symptoms to be able to do something before they become literally a statistic. So we want to be able to intervene while we can. So the wallet card information, this is something that we're hoping that maybe people will fill out and hand to their husband, or hand to their daughter, or hand to somebody. Because if something happens, let's say they have preeclampsia and all of a sudden it turns into eclampsia and they're seizing, they have their name on it, they have their due date, and they can put, have that part already filled out, and they can put this information there. So if somebody needs to intervene, they know some things, they know where things have started. Next slide, please. Okay, so we really need information from you all. We really need to know, did we do okay? Did we do well? Did we address the concerns? Are there things that we didn't add? Everybody in the world knows you cannot put everything you want to say onto 2 pieces of paper. You can't. But what you do need to do is hit all of those check marks that we talked about. It has to be something that's easily understood. It has to be something that empowers people, something that can be understood if it's not in English. So we have to hit every single one of those tick marks. So we want to know, did we do it? Did we make it so that we are empowering people to do more than we have now? Because now we don't have a whole lot in that realm. So we're trying to fill this void. So please talk to us. Tell us what you think.
All right. And the reason I stopped it is because I'm looking to Lisa or Kim, because I think we updated the PowerPoint with the links to the surveys, and I didn't have the updated PowerPoint.
Kim, do you have that?
I do not.
I do not.
I think our moderator does. If somebody is here from our organizers, that would be great if you have that. If not, we can look for the email really quickly, because we want to make sure that you get an opportunity. Also, I put in the chat is our main generic email, cdrc@delaware.gov. So if we really want your input. So we would love to hear from you.
And thank you to Elizabeth Williams sharing this with 911 operators. That's a great idea.
That is a
Yes,
great idea.
That's a
Yes.
great idea.
Yes.
Yes.
That is
yes. So I don't know if our moderators are here, if they can pull up the PowerPoint that we sent to them. She said she never got the PowerPoint.
Well, okay. Then, hey, we're nurses. We always can, hit a ball and run.
Well,
put your email address in there.
Second, I'm going to go into SurveyMonkey and I'm going to put the 2 links into the chat.
That would be great.
Okay, there we go. There we go.
Yes, and Amy asked, is this available for you to print? How can you access it? So right now, we're asking you to take the survey, and the survey will have a link to you can look at it again. So if tomorrow or later today, this afternoon, when the summit's done, you'll be able to access it and give us your feedback. At that point, once we make all of the final changes in May, we're then going to make it available to everyone to be able to print. We'll have printed copies for different providers and community groups, etc. But right now, we're looking for your feedback before you print the copy. Yes, Amy said thank you. Any other questions? And I apologize that we did not have the most current PowerPoint.
one of the things, yes, we're going to have it on VE Thrives. Absolutely, that will be there. But one of the things that we can do once we get this in print, we have 2 minutes left. We really would like, to be able to get it to the people that need it. So we want to put it in the doctor's offices. We want to put it all the places that we know that there are patients. But yes, I love the idea about letting the 911 operators know. We also, are trying to let the ambulances know. We've talked about actually reaching out to EMS, to having paramedics and ambulance personnel know about this. And we've also talked about ERs. So continue to help us think of places that we need to go after. It looks like we're going to be dumped in 44 seconds.
Yeah, Lisa put the professional one in the chat. I don't know about the community one, though.
It's coming.
You have no pressure. 34 seconds. Hi, Siobhan.
This one, the second one is for the community members.
Yes, the one she just shared is your
There you
community.
go.
So
There
if
you
you
go.
copy and paste,
So copy the link, complete a survey for us.
please.
The tool, the front and back page of the handout is in the survey. So you don't have to try and remember what it looked like. So you have access to that when you pull up the survey.
Yep. Thank you guys very, very much. We appreciate all of your help.
Thank you. Thanks for your patience
Thanks
with our
a lot.
difficulties. Bye-bye.
Appreciate it.